So, what is happening in our bodies when we get breathless? Most commonly, the airflow gets slowed down because there's an obstruction somewhere in our airways between our nose and air sacs. There are many reasons why they may get obstructed, and knowing the reason helps explain the diagnosis. These are the main types of obstruction. 1. The most common reason for obstruction is swelling or inflammation inside our airways or tubes. It happens in asthma and bronchitis, the main cause of COPD. The lining and walls of the tubes are damaged from persistent or recurrent irritation from common irritants such as tobacco or cooking smoke or allergens. This leads to inflammation. Mucus containing dead cells or bacteria, phlegm, can also build up because the cilia can't sweep it away. Coughing is our body's attempts to clear this build-up. Or 2, obstruction due to weaknesses in our air tubes. In emphysema, also part of COPD, at the point where the smallest bronchioles reach the alveoli, the air sac walls break down, creating air sacs that are too large. These larger air sacs are too large for good respiration and squeeze the healthy air sacs down. In bronchiectasis, the air tubes widen too much and the cilia, the little hairs, cannot carry the mucus to our throat very well, so the mucus stagnates. Bacteria then grow in these warm, moist conditions. Or 3, obstruction due to small blockages in the air tubes, from a tumour such as lung cancer. Or 4, obstruction due to muscle tightening, forcing the tubes, our airways, to close up. For example, in an asthma attack, bronchospasm, the muscle around the bronchi or bronchioles tighten, bronchoconstriction. Or 5, obstruction due to pressure on the airways, forcing them to close up, for example from tumours not in the bronchus, air tubes, called non-bronchial. If our airways close too soon as we breathe out or exhale, then the stale air gets trapped and our lungs stay inflated. Our next in-breath stacks on top of our last. If you want to try to imagine how that feels, try to breathe in, hold it in, and then try to breathe in again. Meanwhile, as well as obstruction, our respiratory muscles may not work the way they should. Air trapping can also lead to hyperinflation. The respiratory muscles get stuck in the shortened, contracted breathing in position, which may not be very effective, and so we have to work harder. This means we may have more rapid, shallow breathing when we try to do anything. So we may have to use extra accessory muscles, not used in quiet breathing, to help expand our chest and lungs. These are our neck and shoulder muscles. For example, we see this in some sports where people are exerting themselves a lot. We also see this in people where the air doesn't flow well due to lung damage. However, if we need to move or lift up our arms, our neck and shoulder muscles aren't available for breathing, so our diaphragm has to take most of the load. Airways obstruction can increase the work of breathing as much as 8 times our normal. We may feel a sense of excessive work or effort to breathe, like breathing is just a slog. So we can see that both the airways and the muscles may be working incorrectly in obstructive lung disease. This is why respiratory physiotherapy can help. It helps improve the mechanics of breathing by careful advice on body position and breathing techniques such as breathing control, relaxed deep breathing, or pursed lip breathing. These can empty our lungs of as much of the extra air as possible and return our muscles to a better length and our lung tissue to a better state to reinflate and get new air in. This helps reduce the effort of breathing. In addition, weak muscles use more oxygen than strong muscles to do the same work. Therefore, very importantly, rehabilitation and exercise improve the way the muscles work, so we use oxygen more effectively.